I welcome all the participants and on behalf of Dr. Kataria and Vedanta Hospital, and it's a great honor to be a part of this session, and it's a very important session. And I would like to introduce Dr. Judit Heggemann from the University of Medical Center Mannheim, and she's a eminent radiation oncologist, very senior radiation oncologist, and from Heidelberg, and she's been practicing SBRT for I think more than a decade, and she has numerous publications related to this topic to her credit. And Dr. Judith, we are greatly honored to listen from you, to learn from you, and to discuss with you. And over to you, Dr. Judith, now. Thank you so much.
Thank you very much for the nice introduction and also for the invitation. And it's an honor for me that you invited me to do this lecture. And I hope here in Germany we have afternoon and you are already much more tired than me because it's already in the evening. But liver SBRT, I think it's one of the most interesting parts of radiation oncology. So I think it's a nice topic. And I just wanted to talk about the main clinical indications of hepatocellular carcinoma and the new indication, or not really new, but more and more interest is in the oligometastatic situation and the technical considerations for the imaging for SBRT, contouring, planning, organs and risk and constraints, and just the follow-up, the post-SBRT imaging and response assessment. First of all, this is the newest version of the NCCN guidelines regarding first hepatocellular carcinoma. So from this tumor entity, probably you see much more in India or in Asia than we here in Europe. But so maybe I could learn more from you than you from me. However, that's the recent American guideline, and radiation therapy is mentioned in the irresectable stage if bridging therapy is considered before transplantation, or for no transplant candidates as a local regional ablation option. And here is the European updated ESMO guidelines, which has just been published, is a preprint proof. And SBRT is mentioned as a second option in stage 0 and A BCLC, but not on the other stages. So probably this seminar would have been also in person if we didn't have COVID. So in 2021, unfortunately, no lecture without COVID. So I'm also sitting like that guy, and we are sitting in this Zoom meeting, but how can we use this situation and do the best of it? And the largest names in liver SBRT are probably the mother of the liver SBRT is Laura Dawson from Toronto in Canada, and they with several other colleagues also with Marta Scosetti from Italy. They have written a very nice letter now in the Oncologist, especially for the COVID situation. So how could we use SBRT in the COVID situation, and in which situations could we do SBRT? And as you see, they just updated the ESMO guidelines, and in each stage we could use this. And maybe it will be a possibility for us to come out of this this pandemic in a positive way. That we can now offer SBRT also for patients who would not be allowed to be treated with SBRT in a non-COVID situation. And we have now the possibility to collect results and to show that it's a good therapy option. So how should we do SBRT? There are not really good guidelines on that. So the NCCN guidelines allow quite multi-platform and multi multiple choices for planning photons, protons, EBRT, SBRT with anything. So they just propose 30 to 50 gray in 3 to 5 fractions, and they just write it depends on normal organ constraints, and also other schedules with other fractionation can be used if clinically indicated. So there we have the freedom to deliver the radiation as it is suited for the department where we are working it. So this report is already 2 years old, also coming from Laura Dozen. So what are the results for hepatocellular carcinoma? There are some studies, but most of them are retrospective. The 1 year and 2 year local control rates are shown with the blue box. It's very good results between 80 and 90% local control. And of course, the overall survival for this population is as expected, but acceptable. So I don't know how is it in other countries. We here in Europe, in Germany, have large problems in the tumor board discussion with other specialties, especially with the radiologists and the surgeons who are completing other local ablative therapy options like radiofrequency ablation. So we lose most patients on this other local ablative options. And just to know the tumor board argumentation, this is the only study which has been published in the JCOs in 2015, where SBRT has shown better results than radiofrequency ablation, especially in large tumors, so in tumors larger than 2 centimeters. There's a newer analysis, also retrospective, from the National Cancer Database, also in the JCO. These cases were compared, almost 300 SBRT and more than 3,600 radiofrequency ablation cases. Well, this was a retrospective database, and you already see how large the difference between patient count was. And of course, these authors have shown that in this comparison, radiofrequency ablation resulted in a better overall survival. So they conclude that this could be the treatment of choice. We didn't know, as we wrote this small letter to respond to this work, that several other groups had also reacted of this paper. So there was a large criticism, and there was a large amount of letter to editors published in this issue of Journal of Clinical Oncology, where everybody criticized quite the same point, unrelated to each other. So in this study, if you hear it in the tumor board, they didn't deliver any data on local control. We didn't know the Child-Pugh score of these patients, the BCLC stages, and the data of portal vein invasions. And they also excluded patients with neoadjuvant therapy and previous other local therapy. So probably it was a large selection bias, and I think that we should not use this study to argue for radiofrequency ablation. There's a very recent study, again, in an Asian population, SBRT versus radiofrequency ablation. It's a nice paper with propensity score matching. In almost all of these papers, we see this statistical method, probably because we don't have anything what's better, because we don't have any prospective randomized trials. But however, they have shown also after propensity score matching that SBRT provided better local control than radiofrequency ablation among patients with HCC, and the toxicity rates and overall survival outcomes were similar between those treatment modality. So they also conclude that SBRT is an effective alternative for larger tumors, larger than 3 centimeters. They took as a cutoff, and especially for the subphrenic location, so in segment 8. So with other local ablative options, there is a very nice comparison already also 2 years old in the Red Journal where TACE and SBRT were compared. So this was a prospective SBRT database compared to an institutional TACE database, and the results are quite shocking. So the SBRT was really much highly significantly better than TACE. And it was also interesting that the toxicity, they wrote it quite shortly in the paper, but the grade 3 toxicity was significantly more for the TACE patients. And these toxicity were mostly acute toxicity with hypervolemia, cholecystitis, abscess, hepatic artery injury, upper GI bleedings immediately after TACE, in comparison with SBRT, where they mostly saw biliary strictures and upper GI bleedings, and one patient with a radiation-induced liver disease, however delayed, so as a late toxicity. So that's also very recent. It's the same comparison. Also, again, retrospective propensity matched Asian data set where it was possible to show quite the same. So the overall survival was better for the SBRT patient, and also the local relapse rate was lower for SBRT patient than for TACE patients. So, okay, what's the problem? So how can it happen, for example, in Germany, that we still don't really see HCC patients only in the highly palliative situation? Probably that's the point. So all of the prospective randomized phase 2, phase 3 trials were withdrawn. So if you look in the clinical trials homepage, and give these words in SBRT and TACE and liver cancer, then you see that almost studies ended similar ways. So they were withdrawn with no accrual. And that's what it happened also to the European study, the Trendy study, where we also have been initiated as a center. And also as a personal experience and an experience for the quite European SBRT community. So it was the same story. The study has been terminated due to low accrual. And also in Mannheim, we were not able to convince the radiologists to randomize any patients. So I think that's a big problem. So it's the elephant in the room. And I think until we don't manage to have a comparative randomized study, it will stay a problem. But however, I think that probably the combination will be the key. So if we say it is possible to combine SBRT with TACE, or to combine SBRT with radiofrequency ablation or surgery, this is a very nice study where they added TACE with for patients with hepatocellular carcinoma, and then they compared the overall survival for patients with TACE only and TACE plus ablative therapy, and they also did a landmark analysis who were alive at least with at least 6 months follow-up. And you see that the addition of the ablative therapy to the TACE resulted in significant better results in overall survival, and also in the freedom from local progression. And they also try to look at for which diameter do we get the best results. And also for the small tumor, smaller or same as 2 centimeter, very nice local control results were reached if SBRT has been added. So, but also for the larger tumors, large difference. So that's an older study, but in the same direction. So again, after an incomplete TACE, if we add SBRT, then it is possible to just push the patients up to the overall survival range where the patients with the complete TACE can be found. So the SBRT has been shown here also to be a good additional therapy for an incomplete taste. So probably if we have problems with the colleagues of radiology and so on, then I hope that the studies with combination setups will result in the possibility to add SBRT for the patients. This guy is a transplantation surgeon, and he analyzed just as a surgeon, so completely independent of radiation oncology or radiology or whatever. He looked at his patients after transplantation who received 3 different types of local therapy as a bridging therapy. So he had an SBRT group of almost 9%, a TACE group, and a radiofrequency ablation group, which was the largest group. And he analyzed the actuarial survival and also the dropout rates. And he has seen that that this group has seen that the survival rates were the same, independently of which local ablative option has been used. So the SBRT group was the same good as the radiofrequency ablation or TACE for bridging. And he also showed some nice explanted livers, or how the histological reaction looked after SBRT, and how it macroscopically looks like after an SBRT. So that was also, again, an Asian series with patient survival analyzed, the survival after SBRT as a bridging therapy. And they also analyzed the HCC sizes originally and post-SBRT in explanted livers. And the SBRT was able to reduce the tumor size, and the survival was very good in this series. So this is the guideline I mostly like, and this was published before this COVID-19 guideline of Professor Dosen, but it's quite the same what she suggested now for the COVID situation. So the radiation therapy can be helpful in almost all stages of HCC, so we can always think about to be able to help the patient also for single or multiple tumors in combination with other therapies or other systemic therapies. There are some problematic situations. So for example, for the NCCN guidelines, the type C cirrhosis is a contraindication against radiation therapy. So this, it's really a question, can we do a radiation therapy for this patient subgroup? And there are some papers which describe that the toxicity of and the radiation-induced liver disease are more serious in this subgroup. And it was a nice paper who described that SBRT can be also completed for these patients with special constraints and a dose which is then adapted on the liver function. And they have seen that the SBRT was potentially safe and efficacious local modality for carefully selected patients. Okay, so the other large group of patients are the patients with oligomets of diverse primaries. So in Lancet, these are lung pictures, but same for the liver. So the definition of different oligometastatic situations, so de novo oligometastatic disease, metaclone, repeat oligoprogression, and so on, has been published by Dr. Guckenberger. And for these patients, of course, we should think about of treating all oligometastasis with a potentially curative intent. And I think everybody knows this study, the Saber Comet, where it has been the first prospective large trial which has shown that also the overall survival after his patients, the progression-free survival can be significantly better if we add SBRT as an additional local therapeutic option, additionally to the systemic therapy. And this is also the late analysis of this trial, including well-being score and quality of life. And we see that the quality of life has not been compromised, and the patients really profit from this therapy, and the time to the new metastasis seems to be also longer for the SBRT arm. So there's also a nice letter published this January from David Palmer, the author of this trial. Should stereotactic ablative therapy be the standard of care for oligometastatic cancer? And I think based on this data, we can already say, yes, we should talk about with the patients about this therapy option, and we should offer it every patient, and this will probably be also approved in other large prospective trials. So there's a working group of SBRT in Germany with the lead of Matthias Guckenberger. So not only Germany, but Switzerland and Austria and Germany, with almost all cities in these countries, with analyzing all SBRT patients who have been treated in the last 10 to 15 years. So this paper is from the liver and lung database. I think it's quite interesting. So it shows that the probability of death is higher with patients with local failure of the treated metastasis. So the locally controlled metastasis can prolong the overall survival. And this was also a case I wanted to show you. This was a patient with a small cell lung cancer from the clinical routine who already presented with brain mets. So he received first brain met resection and then chemotherapy. And then at that time in 2060, whole brain radiotherapy with 30 gray and then mediastinal RT. And then 1 year later, he developed liver metastasis, which we then, which we irradiated with 5x8 gray because of the localization. No more dose was possible. And then he received some more chemotherapy. And afterwards, he developed a lymph node and the head of the pancreas, which we again treated with an SBRT. Similar like to pancreas protocols, and he, in spite of that he had a small cell lung cancer, he had really an impressive follow-up result. So he didn't relapse since then, and he is living with a very good quality of life and is happy. So I think, of course, these are the cases which for which we are working for, and we hope that many patients will have such results as him. Okay, this is again a table from a review for the liver mets, the results of the local control and overall survival for liver metastasis. So we see that the local control is somewhere between 1 and 2 years, between 70 and 100%, depending of the treating group. And the overall survival is also acceptable. 1 and 2 year, for example, here 1 year more than 75%. And there's also a systematic review from Italy where they all show a benefit for the patients and acceptable liver toxicity, and they also shown a linear relationship between the dose and overall survival and local control at 2 years. So these are the quality of life after liver SBRT. So we see fatigue and an appetite loss after liver SBRT, but mostly that's all. So normally it goes back to the initial level. So it doesn't compromise really the quality of life of the patients. So the German database regarding liver SBRT results, if we compare the results with lung SBRT to the liver SBRT, then we see that the liver is a bit worse on local control than the lung. So for the lung, we have 1 year local control rate of 90%, and 2 year local control rate and 81%. And for the liver, it's worse. So it's the 1 year local control rate is 83%. So we could ask ourselves, what can influence this local control? Why is the liver worse than the lung? And probably we don't really know, but it can be also biological factors, of course, but it can also be a bit of technical issues. So things regarding target definitioning, data repositioning, dose delivery, and motion management. The liver is always a bit more complicated than the lung, where we have a high contrast situation, so and not that much deformations. So this is also from the German data set, where Dr. Andračka looked at what influences the local control, and as published in many other papers. So we see that the patients receiving chemotherapy before the SBRT have a worse local control. Also, the colorectal histology is versus other influences, the local control, and also the dose has an influence. So a higher dose results in a better local control. That is everything which is not that astonishing, but this part I found very interesting. So here they compared patients with SBRT with an advanced motion management. So for this case, it were the pooled CyberKnife and breathing motion managed patients with treated with breath hold versus all other patients, so without motion management or just abdominal compression. And it has been, so we saw a difference. So the advanced motion management resulted in a significantly better local control. So I think it gave us the idea just to pool these patients and look at the long-term results again. So we pooled the patients we treated in Mannheim with deep inspiration, breath hold, and ultrasound-based tracking, and with the CyberKnife patients from Frankfurt who has been treated with implanted fiducials and tracking. And we have seen that the local control was really a bit better than in other published series, and we have seen some differences for the dose. So a higher dose with good motion management can result in very nice local control results. So that's in press now in the Green Journal. Sorry. Okay, how is this comparison with other local ablative methods? So it's again similar like to the HCC. There's a nice comparison from an Italian group with the microwave ablation, where SBRT resulted in significantly better local control results, in spite that the patient with SBRT were older and the lesions were larger. Okay, how do we plan and deliver SBRT? So the first step is, of course, a good imaging for the SBRT planning. So we need additionally to the contrast enhanced CT, also other imaging modalities. And there again, I think the best guidelines are from the Asiatic region, and they already recommended since years that for the planning MRI imaging should be used as a contrast, and also as a diffusion weighted imaging can be also used. So that's also what we do. So on the same week where we plan the liver SBRT, we always do a prima vista MRI in breast hold, which we then match to the planning CT.